So let us discuss our first question. What is the recommended technique for achieving local anesthesia in the maxillary lateral primary incisor in a young children? So the question here asks the recommended technique of local anesthesia in young children. So remember, the best option here would be infiltration. So this is the infiltration anesthesia in the maxillary lateral incisor region. It is recommended technique for achieving local anesthesia in the maxillary lateral primary incisors in case with the young children. So the recommended technique is the infiltration anesthesia. So in the infiltration, that involves the injection of the anesthetic solution directly into the soft tissue surrounding the tooth. So targeting the nerve endings in the area. So this technique, it is commonly used for providing local anesthesia in specific tooth region, including the maxillary lateral primary incisors. So for specific tooth, we can give infiltration anesthesia in the answer of choice here would be D. Moving to the next question. Which statement is true regarding the use of intraligamentary anesthesia in the upper jaw? The answer here is C. The intraligamentary anesthesia is often used as a supplement technique in the upper jaw. So intraligamentary anesthesia, it can provide effective anesthesia for the specific tooth that is being treated. So the intraligamentary anesthesia, it is frequently used as supplementary technique in the upper jaw. So the infiltration technique, they are the commonly used to provide reliable pain-free anesthesia. Intraligamentary anesthesia may be used in addition to enhance the anesthesia for specific tooth when the infiltration alone may not be sufficient. So answer here is C. Option A, reliable pain-free anesthesia is possible using intraligamentary anesthesia. This statement is not entirely true. As the intraligamentary anesthesia, it can provide effective anesthesia for specific teeth being treated, and it may also not always guarantee pain-free anesthesia for all cases in the upper jaw. So that's wrong. Second option, it is primarily used for providing anesthesia to periodontal ligament. It's the infiltration technique, it's the most important we use, and it is primarily used to providing anesthesia to periodontal ligament and bone surrounding the specific teeth. So the injection is made into the PDL space. Option D, it eliminates the adjacent tooth anesthesia in the upper jaw. So it aims to provide anesthesia to a specific tooth. So it does not necessarily eliminate anesthesia in the adjacent teeth. Adjacent teeth, they may still require their own anesthesia if needed for the dental procedure. So answer here is C. During nasopalatine nerve block, the nerve, it is inserted into which area? Well, during a nasopalatine nerve block, the needle, it is inserted into the incisive foramen. It is inserted near the incisive foramen. So the nasopalatine nerve block, it is performed by injecting the anesthetic solution near the incisive foramen to anesthetize which nerve? It's the nasopalatine nerve that provides sensation to anterior anterior part of the hard palate. The greater palatine canal, it is associated with a different nerve block technique and not the greater palatine nerve block, it provides anesthesia to posterior part of the hard palate. Infraorbital canal, it is associated with it is not the relevant answer. And pterygomandibular space, it is associated with the inferior alveolar nerve block. So your answer is incisive foramen. Moving to next question. After a long nerve block, the patient complains of temporary difficulty in chewing and controlling food in the mouth. What could be the nerve that could be affected? Well, the answer here is a trigeminal nerve. The trigeminal nerve, it is responsible for the sensory innervation to face and motor innervation to muscle of mastication that are involved here in chewing. So anesthesia to the branches of trigeminal nerve such as the long buccal nerve can temporarily lead to difficulty in chewing and controlling food in the mouth. Hypoglossal nerve, it is a nerve that is responsible for movement of the tongue. So anesthesia of the hypoglossal nerve, it results in tongue weakness or difficulty in articulating certain sounds, but it won't directly cause difficulty in chewing or controlling food in the mouth. So option B, facial nerve. Anesthesia of facial nerve might result in temporary facial muscle weakness or palsies, but it does not affect chewing or controlling food in the mouth. The glossopharyngeal nerve, it is primarily responsible for swallowing and throat muscles. So anesthesia of glossopharyngeal nerve might affect swallowing, but it is less likely to cause difficulty in chewing or controlling food in the mouth. So that is why your answer is trigeminal nerve. During an infraorbital nerve block, the patient experiences severe pain and swelling in the area of injection. So that could be due to the answer is accidental injection into blood vessels. So if during infraorbital nerve, so while you are giving an infraorbital nerve, what happens is the needle accidentally punctures a blood vessel, and anesthetic solution, it is injected into the bloodstream. So that could lead to severe pain and swelling. So the anesthetic solution, it can irritate the blood vessels and surrounding tissue, causing this reaction. The infection at the injected site. Infection at the injected site, option B, it can indeed cause pain and swelling, but it does not typically develop over time, and it is not an immediate risk to the swelling itself. Option C, allergic reaction to anesthetic solution. Allergic reaction to local anesthesia, they are rare but possible. So they are associated with itching or rash or systemic symptoms. The patient experiences systemic symptoms like breathing, drop in BP. So they are not typically allergic reaction symptoms. So answer here is A. Anesthetic toxicity, it can cause systemic symptoms like dizziness, confusion, tremors, seizures. So that are not mentioned. So answer is obviously A. Following an infraorbital nerve, the patient reports numbness in the upper lip and gingiva, but still experience pain on the maxillary central incisors. So answer here is option D. So the middle superior alveolar nerve innervates the maxillary central incisors. if the needle accidentally inject the anesthetic solution into the middle superior alveolar nerve, that could lead to numbness in upper lip. That is the area that are supplied by infraorbital nerve. So the accidental injection into the middle superior alveolar nerve that is related with the numbness in the upper lip, teeth, gingiva, with pain on the maxillary central incisors after an infraorbital nerve block. It suggests that accidentally injecting the solution into the middle superior alveolar nerve. So the middle superior alveolar nerve innervates maxillary central incisors, and its incomplete anesthesia can lead to this cause. During a nasopalatine nerve block, the patient experiences sudden severe pain, bleeding from the injection site. So during a nasopalatine nerve block, the patient experiences sudden severe pain and bleeding from the injection site. So the sudden severe pain and bleeding from the injection site during nasopalatine nerve block, it will suggest accidental injection into the greater palatine artery. So the greater palatine artery, it is located in close proximity to the nasopalatine nerve, and its accidental puncture could result in pain and bleeding. Following a greater palatine nerve block, the patient complains of persistent metallic taste in mouth. So persistent metallic taste in mouth after greater palatine nerve block, it suggests the anesthesia of the chorda tympani nerve. It is a branch of facial nerve that provides sensation to anterior third of tongue, including the taste of the metals. So answer here is D. Following the maxillary nerve block, the patient reports numbness in maxillary teeth and palate, but they experience pain when the pressure is applied to the gingiva. So the answer is B. If the needle accidentally punctures the greater palatine nerve during the maxillary nerve block, it can result in numbness in maxillary teeth and palate, but leave the gingiva that causes pain when pressure is applied. Which nerve block is targeted in the mental nerve block? Answer is the mental nerve. A mental nerve block specifically targets the mental nerve that provides the sensory innervation to lower lip and the chin, whereas the lingual nerve, it is responsible for providing the sensory innervation to anterior 2/3 of tongue, and it is not the primary target of the mental nerve block. The inferior alveolar nerve, it provides sensory innervation to lower teeth, gums and lower lip, and it is not the primary target of the mental nerve block. The buccal nerve block provides sensory innervation to cheek and buccal mucosa. So answer is A. Which nerve is anesthetized in palatal anesthesia technique for maxillary teeth? The answer is nasopalatine nerve. So the palatal anesthesia technique primary targets the nasopalatine nerve that provides sensory innervation to anterior part of the hard palate. Which of following is a potential complication of inferior alveolar nerve block? The most important and potential complication that is associated with inferior alveolar nerve block technique is the lingual nerve that runs close to the injection site, and damage to it can result in lingual nerve numbness and altered sensation. So answer is A. The palatal tissue necrosis, it is not a common complication of IANB. TMJ dislocation is not a direct complication of inferior alveolar nerve block. Increased salivary flow, it is not typically complication of inferior alveolar nerve block. Answer is A. A patient reports numbness and altered sensation on anterior 2/3 of the tongue. So the question here say anterior 2/3 of tongue. So that will be anesthetized by lingual nerve. So numbness and altered sensation on the anterior 2/3 of tongue indicates involvement of which nerve? It's the lingual nerve. What is the potential complication of Go-Gates technique? The same lingual nerve damage. The lingual nerve runs in close proximity to the injection site, and that can result in temporary or permanent lingual nerve damage or the altered sensation. Nasal intubation, it is most commonly used in the otolaryngology study, such as the sinus surgery, septoplasty and various nasal procedure. So the answer is C. Dental surgery typically do not require nasal intubation. Oral intubation is more common in dental procedures. Which of following is contraindication for nasal intubation? So the answer is C, nasal polyp. Answer is C, epistaxis. So nasal intubation, it is contraindicated in the cases with the active or recent nose bleeding. So due to the risk of worsening bleeding, it may compromise the airway. Nasal polyp may obstruct the nasal passage and make nasal intubation more difficult, but they are not absolute contraindication. Deviated septum can make nasal intubation more challenging, but it is not the absolute contraindication. The oroantral fistula, that is abnormal connection between mouth and maxillary sinus, may make nasal intubation more challenging, but it is not the absolute contraindication. So answer is C, epistaxis. In patient with extensive maxillofacial trauma involving the leaf foot fracture and mandibular fractures, which intubation will give the best access and stability? It's the submental intubation. So in the submental intubation, that is the technique that involves the passing of this endotracheal tube through a submental incision and then advancing it into the oropharynx. The oral intubation, it is most commonly approach. It is a common approach for airway management, but in case of extensive maxillofacial trauma, it may interfere with the surgical field. So in patient with extensive leaf foot fractures and the mandibular fracture, the intubation that offer the best access and stability is the submental intubation. So that will allow it to bypass the fracture facial structures and avoid interference with the surgical field. The patient with a cyst at apex of upper central incisors that measures 1 cm in diameter and it is confirmed by aspiration biopsy. Which method of treatment would you consider? So you will make a mucoperiosteal flap, remove the cyst through opening in the alveolar bone, followed by endodontic treatment. A 33-year-old patient presents with throbbing pain and swelling over the mid-palatal region since 3 months. The patient has a history of trauma to upper front teeth during his childhood. On examination, you notice a mid-palatal swelling that was firm in consistency, non-tender, and the teeth was discolored and non-vital. Your diagnosis would be, well, the radicular cyst, we know that it is found commonly seen in non-vital teeth like the central incisors. It is the common presentation of radicular cyst. The radicular cyst has a well-defined radiolucent area as seen in the radiographic image. So radicular cyst, it develops as result of pulp trauma or any infection, and we can see a well-defined radiolucency in the radiographic image. So answer is radicular cyst. The following is an example of true cyst. The answer is residual cyst. A true cyst is defined as pathological cavity that is lined by epithelium. The Stephanie cyst, it is not a true cyst, it is a pseudocyst. The traumatic bone cyst, it is a true cyst. And it is characterized by cavity within the bone, and it is caused by trauma. It lacks epithelial lining, but it is still considered a true cyst. The residual cyst, it is a true cyst, and it is formed from remnants of earlier cyst that has been partially removed or incompletely removed. So answer is C. Oxygen should be stored in. So the oxygen tank, they are always stored upright and secured tightly in place. So your answer is vertically and secured. The oxygen should not be stored outside the office without proper security measures, and protection from environment factors is important. A 20-year-old male that presented with small swelling in the front of neck in midline, the swelling that moves with upward on protrusion of the tongue. So as the patient moves his tongue, protrude his tongue, the swelling moves upward. The answer is thyroglossus cyst. So it is a classic presentation of thyroglossus cyst. During submandibular incision, the closure is completed in 4 layers. So the answer is A. Platysma, tergomesenteric sling, subcutaneous tissue, and skin. The diffraction osteogenesis in child differ from that of adult in that is the faster rate of diffraction. In children, the diffraction osteogenesis can proceed at faster rate due to their robust healing response. Diffraction can be initiated immediately, or rate of diffraction, it can be rapid, typically around 1.5 mm per day. So the faster rate of diffraction that will allow quicker bone formation.